As you know, I'm Mellissa Beck, the Executive Director of the Sozosei Foundation. Again, so excited and pleased to have so many of you with us today. I know it's hard to pull ourselves away from the wonderful snacks outside, but if you can hear my voice, it is time to put your smoothie down. Boy, I'm so excited to be here with the two of you. For those of you who were with us last year, on stage with me today are two extraordinary leaders representing the state of South Carolina. And I'm excited to have this conversation, not just because of the talent to my left, but because the panel that came before us really set this conversation up well. Because what you're about to get the gift of is a state-based view of 988. So try to hold in your mind everything you just learned about 988 nationally and get ready for a case study in real time. So to my left is Dr. Kenneth Rogers, who was formerly the head, you had a long title, Ken, so I have to do this. The former head of the state director of the South Carolina Department of Mental Health. That's right. And he's currently the vice president and chief medical officer of behavioral health for WellSpan Health. And to Dr. Rogers' left is Allison Farrell, who is currently the executive director of Columbia Area Mental Health. So we wanted to start with you, Dr. Rogers, as we did last year, to ask you to please level set on the state of behavioral health care access and the criminalization of mental illness in the state of South Carolina.
In South Carolina, I think we've done a lot over the course of the past year or so. We have done a lot in terms of trying to get people out of jails. We had a lot of folks that were really jailed because of competency and restoration issues. We've done a lot of work with trying to get those people out and doing more community-based restoration. One of the things I noticed when one of the panels earlier, they were talking about, deep end services, especially for jails. And like a lot of states, South Carolina spent a lot of money in jail-based care versus some of the front-end care that you would expect. And so I think that we're kind of in a mixed phase at this point, and in terms of where we are as a state, some going positively, some not so positively.
Mm-hmm. Last year, you told us a little bit about some facts and figures, number of hospital beds, some workforce issues. Can you speak into that a little bit?
Sure. One of the things in terms of level settings, the Department of Mental Health in South Carolina is a really unique agency that's really different than all except one other mental health system in the United States. We're a state-based entity, so we have 16 mental health centers that cover all 46 counties in South Carolina. Everything is state-run. All of our counselors are state employees. Our mental health centers are state entities. We also have 2 state psychiatric hospitals that have a total of 210 beds or so, as well as a substance use facility that's there. What's unique about South Carolina is we also operate the state's veterans nursing homes, and there are 5 of those spread throughout the state as well. We also have a hospital for children, as well as in the process of building a residential treatment facility for adolescents from the juvenile justice system.
Thank you for that. Allison, over to you. I know, I've just promised the audience this is going to be a case study on 988 implementation, so perhaps we should just get that promise done and start there. Can you update us on what's happening 988 in South Carolina?
I can. So 988 in South Carolina, I'll just start with this, is currently unfunded. We did not get a fee placed on our phone bills the way that these other 5 states have, that somebody was talking about earlier, which presents issues, as you know, when there's no funding for it, but you've got this mandate. We've seen an increase in call volume, an increase in, that's to the Lifeline. Also seen an increase of 74% between 2020 and 2022 in self-harm calls. From EMS, which I think gives us a fairly sad but accurate view of how important it is for us to get our 988 system established. We have 1 Lifeline in South Carolina, and we're in the process of implementing another one, a backup call center, so that more of our calls can be answered in the state. Currently, the in-call answer rate is only about 65%.
You've 1 Lifeline. Dr. Rogers, I think you've taught me that there's 5.5 million people in South Carolina?
There are 5.5 million happy citizens of South Carolina.
And so there's one call center, Allison.
One call center.
So,
But let me add something
Yep,
to what
go ahead.
Allison was saying, because it kind of will help you understand, I think, where South Carolina is. They're a state that they don't believe in unfunded mandates. That's kind of the big thing that they preach all the time. If the federal government says that we should do something, then they feel like the federal government should pay for it. And so there's been a lack of funding for 988. That being said, this is also the biggest surplus that the state of South Carolina has had. So we got $3.4 billion in American Rescue Plan funding this past year, as well as $2.4 billion in state budget surplus. If you look at the amount of money that was actually given to mental health during that time period to the Department of Mental Health, I would have you guess, but it was actually $0. And so there's really a disconnect between 988 and the relative importance of it versus other things that they have chosen to do with that money. And part of it has been the question of why do we need 988? And that's been actually the largest internal discussion. 911 exists. Behavioral health folks can call 911. 988, that's something else that's not really funded. It's not really going to benefit us. So do we actually spend money in trying to do it?
well, thank you for answering and enhancing the answer there, Dr. Rogers. So let's talk a little bit about, Tiffany was talking about her work at Pew on 911, 988 interoperability, and some states that have voluntarily come together to talk about that particular issue. So are those conversations, as you say, Dr. Rogers, in South Carolina, that we don't, I'm shorthanding here, forgive me, 988 isn't really a priority because we have 911? Is there any discussion about true interoperability of these systems?
With 911?
Yeah.
I think there's discussion. I just don't know that there is an identified mechanism so far. And I don't know that it's for lack of interest, but I think obviously that's a complicated endeavor that would involve pretty intense collaboration. We also have the statewide mobile crisis system in South Carolina, which I'm particularly really proud of South Carolina on this. It's we have 46 counties, and mobile crisis teams function in 46 counties 365 days a year, 24 hours a day. And last year we deployed 7,500 times throughout the state. So I think that adds another layer of do you really need, this isn't coming from Allison, Farrell, this is coming from other people, but do you really need with this robust mobile crisis call center and this highly functional mobile crisis system, how much collaboration is really needed on the 911 side? And the answer is a lot, because we want people not getting involved with the police necessarily, you know what I mean, if we can get them involved with mental health supports.
Mm-hmm. So when there is a mental health emergency, Allison, if you could just sort of bring this forward a little bit more, can you walk us through kind of what a typical response might be in South Carolina? I know last year you reflected a little bit on rural, urban differences and challenges.
So if, now this is calling 911, right? So if someone is in a mental health emergency, they call 911, law enforcement will deploy, now this is across all 46 counties, they will deploy, and if there are strong relationships with our mobile crisis teams, then law enforcement, typically on scene or on their way to the scene, will decide, hey, I need mobile crisis backup, right? So it's always 2 clinicians that go out once they're on scene. Law enforcement just makes sure that it's safe, and then they stand back and it becomes a mental health scene. It becomes that law enforcement is there just to make sure that everything is safe, but the clinicians really drive the work on scene. In some counties, Richland County, for example, which is where the mental health center is that I direct, we have CIT teams in place, and that is where a 911 call can immediately be diverted to a mental health clinician that is in plain clothes with an officer that's in plain clothes, in a plain clothes vehicle that can respond to that 911 call and try to really divert from emergency rooms and jails. There's a lot of discussion around should mobile crisis go out with law enforcement. We got into this a little bit last year. That's South Carolina's practice. But I do think that we have it working fairly well and fairly smoothly, and that the clinicians have pretty broad overview of that response, and that law enforcement is trusting and collaborative with us on that.
When you both look at that collaboration, and I'll circle back on some rural stuff, which I'll just put in the parking lot for a sec. Is there someone sitting at that table who is saying, well, this is all great. We have this co-responder model working. Why aren't we using 988? Is it 988 on the radar, or is it really just not? I'm trying to understand.
You want me to go or you to go?
I'll go. So I think you have to separate people's thoughts around 988 and crisis response. I think in a lot of places, those two things have gotten linked. In South Carolina, the conversations really are unlinked. So if you look at crisis services, I think we actually do relatively well. So Allison talked a little bit about our crisis response. We have these Class A RVs with 2 offices that can deploy anywhere in the state fairly quickly. We should be able to get to any crisis in the state of South Carolina within 30 minutes. And so in terms of crisis response, mobile crisis, I think we're in really good shape. We're in the process of trying to build more brick and mortar crisis centers that law enforcement and others can take someone to. There's actually a budget request to do that in this upcoming budget this year. And so I think that's part of the move. So the conversation becomes, if you have a robust crisis system in place, do you need 988 to move people into that crisis system? And so I think that was part of the initial debate that was occurring. As we've kind of gone further into the future and kind of where we are now, I think there's a realization that it's a movement nationally. I think there is going to be more movement in that direction, but again, it's viewed as an unfunded mandate. Dollars are getting pulled from somewhere else. And if you're pulling those dollars from somewhere else, what are you losing in the process?
Mm-hmm.
I also don't know that the public, and you can agree or disagree with this, I don't know that the public understands that 988 is a series, right? And it's a system versus just a phone number that you call. Like that it has all of these layers of diversion and support that I'm not sure that the community recognizes as being part of the system of who do you call, who responds, where could somebody go, which is where you get into the crisis stabilization.
Absolutely agree with that.
Mm-hmm. What do you think from a South Carolinian's point of view who might fear calling 911, who might be better off calling 988, doesn't want to call 911 out of a fear of law enforcement response? That's to either of you, of course.
Yeah, I think the opposite actually occurs more frequently because 911 is actually a known entity for folks. Mm-hmm. And in South Carolina, I think the Department of Mental Health has done a really good job of trying to, one, decrease stigma. So there's a lot of anti-stigma campaigns that have occurred. Our mobile response is often triggered through calls to 911. And so there's a real, long history of actually using 911 for positive purposes. And so I haven't seen a lot of resistance to using 911 or having really bad outcomes related to 911 calls.
Yeah.
And so I think it actually has ended up being more positive than negative.
Yeah. Allison?
Well, I was just going to say, I think as mobile crisis has become more well-known and more accepted, that it has neutralized some of the fear of 911, especially if it's a family member that when they call says, I want mobile crisis to come out, which happens in South Carolina now, where they might call 911 and say, I want mobile crisis to come out. And so then that's immediately put into effect, right? And you can kind of get those teams mobilized. Whereas if you call 988, their job, and they do an excellent job of this, and they really do, of their job is to de-escalate, to be supportive, to connect to resources. And then if they are not successful with that or someone cannot be safely maintained in the community, then they will reach out to 911 and/or mobile crisis, because mobile crisis has its own 833 number. So it has its own toll-free number that last year was utilized over 25,000 times.
Wow.
So there's I think a lot of ways to access the system that there's maybe less fear around 911, especially for people that know about mobile crisis.
Yeah. Can you envision a time where, and thank you, Allison, I think you just said 833, did I get that right? Where 988 plays a bigger role in South Carolina? Like, from the two of you with your expertise, when you sit back in 5 years at the summit, will we have a different conversation about 988, or is it really just not going to be the way in South Carolina as you see South Carolina?
No, I do think it will become much bigger. One of the things that happened this past year is across the state, both at the college level, but also, elementary, high school, middle school level, suicide response lines, crisis line numbers were actually put on the back of ID badges. 988 was added to that. And so I think what you will see over the course of the next several years is a recognition of 988 being linked to a lot of these other services that exist, especially for children and young adults. And I think as that begins to occur, I think you will see more movement toward the use of 988 versus 911.
Right. And I'm going to tack on to that, presumably more money. Yes, for the one call center, so more staff.
And more places to go.
Yeah.
Right? I mean, more places for people to go that are not an emergency room.
Right. So let's pick up on that, because I think, Dr. Rogers, you mentioned bricks and mortar. And, there's not enough psychiatric beds, as I understand it, in South Carolina. And so is it a physical issue that there are not enough buildings? What's happening?
Well, I think that South Carolina is like a lot of states. And there's this dilemma between current state and future state. So 988, I think in a lot of people's mind, is really a future state, because for folks, it's really a matter of how do you link this number to the crisis services that already exist. If you talk to the legislators in South Carolina, the big push is we don't have enough psychiatric beds in the state. And so if we're going to spend money with funding, do we actually build more bed capacity across the state versus using it in these other areas, which gets into a prioritization of how do you prepare for the future and how do you kind of live now. And I think that the bed debate is probably going to win out for the next couple of years, in all honesty, because there is a lack of beds. So for 5.5 million folks, you've got, at this point, functional bed capacity about 190 beds in a state the size of ours. So it's incredibly low in terms of public beds. So there's a need that's huge.
So what's happening in the state to address this with bricks and mortar and creating space for more beds? Anything? Allison, I think you have some thoughts on this, if I recall.
I do. So we received, for Richland County, $1.3 million in one-time funds. So mathematicians, y'all do the math here. To create a standalone crisis stabilization unit where people could stay for up to 14 days. It would be fully staffed, psychiatric access, nurses, clinicians. So we looked, and when I say we, I got in my car with a real estate agent and we drove all over Columbia trying to find something that would meet the rules and regulations that our Department of Health Environmental Control had established. Now, if you've not ever looked through that and you want some great bedtime reading, go ahead and knock yourself out. And if you can figure out any red tape in there I can get around, let me know. But it's about that big. And for something that, it's hard to grasp just the complexities, right? For me, it was. I was just like, oh my gosh, it has to have ground level windows. Okay, so now we're just looking at buildings with ground level windows. So anyway, so then we kind of backtracked and said, we're going to look at buildings that we already have access to through the Department of Mental Health. So that was a young adult clinic that's been functioning for, I don't even know, Dr. Rogers, 20 years maybe, right? Perfect. It had a shower and a kitchen, and it had 5 great offices that were on the ground level, and they all had a window in the room, and it was just wonderful. I mean, it was in my mind, perfect, right? So we jump through all the hoops of getting engineers and this and that. So now we're about $30,000 into just the feasibility study for this building. Anybody want to take a guess out of our $1.3 million what they came back with that it needed to be renovated for? $1.7 million. So when even for me, the disappointing part was like, how do we bridge this gap between resources, right? Like, how do you say, like, here we are trying to do something that is already established, and I'm thinking just grab bars, y'all. I mean, maybe I'm just really clueless, but I'm like, maybe just need grab bars in the bathrooms and some sprinklers. Like, I don't know, but it needed $1.7 million, and you can do that to a building, and then I have no operating budget to hire staff and to serve patients. So it was disappointing. So now we're going to do a crisis receiving unit. If anybody in here has a crisis receiving unit, one of the less than 24-hour units in their state, and you know about it, please find me and talk to me about it, because that's the direction we're headed in now. So,
well, sounds like a smart pivot, Allison, and you're in the right place for collaboration here at the summit. So I'm sure you'll have a line around you at dinner. But in the meantime, I think another thing that this goes out to all the private philanthropies in the room that often we don't think about is, there are ways that private philanthropies can support capital infrastructure, purchasing buildings and renovating by making program-related investments, which you essentially give a loan to an organization to do the work rather than them having to go through a bank or other interest rates. So that could get very boring very quickly, so I'm going to stop talking about that, except say, when you're talking to Allison, you can talk to me about program-related investments, and it will be much more spunky than that was. Speaking of spunky, I remember last year, one of the things that really impressed me in our conversation, and Allison, you've been percolating this quite a bit, is that South Carolina takes its data very seriously. And Dr. Rogers, I recall you spoke about some partnerships with universities between behavioral health care. And when I traveled around the state and spoke with some of our other grantees, they were referencing that and an eagerness to hear a little bit more. So can you talk to us about partnerships with universities and how you all are using data to pivot and shift and move forward?
Sure. One of the things that we have done at the department, and it started before I left, but also is continuing to expand, is our relationship with the University of South Carolina, but also our relationship with the state Medicaid agency. So one of the projects that we had for this past year, for example, is school mental health. We run 70% of the school mental health programs in the state of South Carolina. And we wanted to understand the effectiveness of those programs. And so we actually went to the Department of Psychology at the university, who actually was able to help us collect data looking at financing options, looking at uptake and use of the programs that currently exist, and kind of how to think about better utilizing the master's level therapists that we have. Because one of the things that we have in South Carolina, like most states, is really a shortage of master's level clinicians to provide services. And so working with the university and with our state Medicaid agency to do those kind of studies has been particularly healthy. And we're continuing to do that across a number of other things that we're doing as well. And so I think that relationship has worked well. We're also looking at a crisis mobilization program with Clemson University, where we actually have some folks from the School of Nursing that are doing more somatic health, physical health stuff. They're actually going to be paired in those RVs with some of our folks that are doing mental health care. So looking at, can you co-locate a mental health, physical health model to actually provide services in rural South Carolina, because there's a shortage really of both. And so trying to figure out how can you get folks coming to the RV for one appointment that's actually going to hit both sets of needs.
This is the second time or third time the RV has come up, and it makes me feel curious, and I know we want to get to you on the same data question, Allison, because I know you love it, is we haven't mentioned telemedicine in South Carolina. Is there a reason?
No, South Carolina actually has a really robust telehealth system. It was actually one of the first telehealth systems in the country. We're actually one of the larger telehealth providers in the U.S. We can actually cover many of our emergency rooms in the state. We're also actually able to engage with our mental health centers. When we had to shut down because of COVID, we were able to go to mobile and teleservices actually within a week. It was almost a seamless transition that occurred. We continue to have a cohort of psychiatrists, child psychiatrists, and adult psychiatrists that are totally telehealth employed physicians that do all of the telehealth services across the country. And each of the mental health services centers, as Allison was talking earlier, actually have a telehealth component themselves. And so it's very robust. The problem you run into in South Carolina, being a very rural state, is broadband issues. If you get into rural South Carolina, you can't use telehealth because you just don't have the broadband capacity.
Has there been any innovation around that, Dr. Rogers, around the lack of broadband, sort of clusters of cell towers or anything in more rural areas where people could gather?
Yeah, a couple of our state representatives, especially Representative Clyburn, that's been really their push, is trying to get broadband into some of those rural areas. It's gotten caught up in a lot of politics. And I think that has really slowed down the process of who pays for it, where is it, which company does it. I mean, you name it. It's slowed things down, but there is a push to try to make it work.
Yeah, politics can get in the way. Allison, I promised you, we'll just leave that there. Allison, I promised you that you could talk a little bit about data, because I know that that's informed a lot of your innovation. I mean,
it really does, yeah.
So can you tell us about
So our data, right now I talked earlier about, the EMS data, the 70% increase in self-harm calls over 20 to 22. We obviously rely on a lot of Lifeline data in South Carolina for 2020, which was the last year that we have the data available nationally for suicide rates. Nationally, they went down. In South Carolina, they actually edged up. So that really informs us in terms of, what are we training these mobile crisis clinicians to do? That, along with the self-harm calls, knowing that those are up, helps us. We get a lot of valuable information from our mobile crisis call center too. It's very interesting to see kind of who calls. Like, it's a lot of times family members that call who want help, who are more hesitant to call 911 maybe because they would have had a bad experience if they've had a bad experience with law enforcement. And then we have to have the conversation about that we only respond with law enforcement, but that tends to kind of mitigate itself once we explain the process. We're looking now at an app that would actually help us understand more about the deployments with these clinicians in real time. So tracking our average response time in South Carolina, it needs to be less than 60 minutes, but the average response time right now is 17 minutes for a team of 2 clinicians to actually get on site. That does not always mean that law enforcement is there in 17 minutes, so just keep that in mind. But 17 minutes, and then their average time on site is typically 30 minutes, right? But we would be able to kind of link, like, are these longer response times interfering? Because sometimes if it's a longer response time, then the family has left or somebody else has kind of come in and gotten things smoothed over a little bit, or unfortunately, sometimes that means that somebody has gone to jail, So I think that piece of data collection is really important for South Carolina right now to help take us to this next step, especially in terms of funding. Also, too, our need to incorporate peer support more in our responses. Data has shown us that people want that, they respond to that. So we do have a grant from SAMHSA over the next 2 years to place peer support specialists in lieu of one of the clinicians. So it would be a peer support specialist and a clinician that actually responds, and that also have access to iPads for a tablet of some sort, so that they could do an intervention in some of these rural areas if they can connect, to try to capture those responses that we might be missing otherwise.
Could it be possible that those tablets might also be used for telehealth?
Yes, so even on our Highway to Hope, which is the RV program that Dr. Rogers has mentioned, so each mental health center has this RV. It is fully equipped with telehealth so that we can connect to a physician. And I am not the most savvy technology person, but there's some sort of pack that can go on an RV that bounces off of like all the cell towers, so that if you can't get Verizon, you can get some of the other ones. Those are on there too to kind of help us connect in areas that we may struggle. I'll remember the name in 10 minutes, but I'll let you know.
You may still be here.
Or tonight when I'm laying in bed, yeah.
That's all right. Just put it on.
I'll get back to y'all tomorrow.
Right.
what that
You
thing's
can
called.
use the Whova chat function. Let's go back to 833-911-988, right? So there's 3 numbers. Are there more numbers before I start going on?
833 no, 833-988-911.
Okay.
And there's some regular 10-digit numbers that people can
Yeah,
call.
the regular.
The regular
Thank you,
numbers.
Dr. Rogers. Yeah. Okay, sorry. How do those systems know when to ping one another? So if somebody calls 833, how are the people answering those calls? Do they have a protocol, a series of questions, validated questions, evidence-based, and then they say, oh, I need to call 911? How does that work?
Well, it depends on where it goes into, right? So if it goes into the 833 to the mobile crisis number, there's not a direct connection. It's let's get you over to Lifeline, and here's the number, or here's the chat line, the chat text line.
I see.
911, they will call, the officers would call, as they're being deployed, they would actually call the 833 number. And you think of other...
And there are some where we have actually a clinician with the 911 dispatchers.
We do have a clinician embedded in Charleston's dispatch. Yeah.
And if there's not a clinician in the dispatch, is there are 911 operators trained about this is clearly a behavioral health issue? Like, how are the individual human beings making the decision about when to call into these other systems on behalf of the person who's having a crisis?
I think it's fairly subjective, to be honest.
Okay, that's helpful.
Yeah. I think it's fairly subjective. I do think that, like in Richland County with 911, their dispatchers are trained knowing that they have the CIT teams in place, right? So they will just push that straight to the CIT team.
Got it.
In other counties, CIT is not an option a lot of times. So those dispatchers would default to law enforcement.
Yeah, and South Carolina really has 3 heavily populated areas: Charleston, Columbia, and Greenville. So those 3 areas tend to function pretty much the same. I mean, all the services are there. It's easy to transfer someone. Once you get into the other 43 rural counties, it's a very, very different animal.
Yeah.
And so things are a lot less linked in those areas than they are in the more metropolitan areas.
I feel as if some of our conversation has been rather pessimistic. And so, it's kind of, we can liven it up. We've got to set a good positive stage for the crew from Philadelphia. What's happening in South Carolina that makes you feel optimistic?
See, I don't think our conversation has been.
All right, maybe I'm just hearing it. Maybe it's my vibe.
I think.
Or we're just numb to it.
I think there's some great things happening in South Carolina. Again, we have mobile crisis. We can get to people in 17 minutes across the entire state. We have school mental health programs that are spread throughout the entire state and are highly available. We have 16 mental health centers that are either in that county or have satellites in 44 of the 46 counties in South Carolina. There are actually over 1,000 ways that somebody can access care in South Carolina. So access and the care that exists, I think, is actually really good. And I think that there are benefits to having a statewide mental health system.
Yeah.
Where from Columbia, we can look at the data and know where things are being done. We can utilize care. We can roll out things fairly quickly. And so I think there's a lot of positive things that are happening. I think that our conversation really centered around 988. And I think if you look at South Carolina in terms of crisis response, I think we're actually in a good place. And we're continuing to go to, I think, even more positive places. Where I think we struggle is linking with what's actually happening nationally. And here's the struggle with having a state system that's different. So if you look at SAMHSA, SAMHSA funds individual mental health centers. Because we have one system, if SAMHSA rolls out something that's going to benefit mental health centers across the country, we can only apply one time. And so our funding federally is impacted because of the way our system is developed. And so that then requires more state funding to operate the system that currently exists, which I think is a really good system. But it's really at odds and different than the rest of the country. So I think that's part of the struggle that we as a state have had.
That's very particular and specific and things.
It's very specific to South Carolina.
It's interesting. Well, you can talk to Tiffany for 10 minutes.
So I have happy things to
Yeah.
share. So fun fact, y'all, how many access points in South Carolina?
There are over 1,000.
Okay, so Waffle House, every time I see a Waffle House, I think about this. There are more ways to access mental health in South Carolina than there are Waffle Houses. Yeah, isn't that impressive? Isn't that impressive? You are never far from a Waffle House, which means you are never far from access to mental health. Okay, so I think we are doing an excellent job, and we have a real gift in South Carolina that our law enforcement has bought in, and that our law enforcement agencies do not want, they want to see people with mental illness taken care of and not in jail. And I think that's a pretty broad sweep, and I think I can say that the majority of law enforcement agencies in South Carolina are doing an excellent job of getting on board with this and of doing and working differently. They really are. Another project that we have going on right now is a long-acting injectable pilot, where we were funded once again with some one-time funds, but that's better than nothing, to actually partner with our detention centers, so local detention centers, not our prison system, local detention centers, which in South Carolina are typically run by the sheriff, to actually reimburse them for starting to use long-acting injectables when someone is detained. And this is huge. And in the areas that they're using it, there has absolutely been a noticeable difference. And I don't have data for you on that today, but hopefully next year I can, because it really just got kicked off. But it's allowing people to continue on their injectable medications while they are detained. So if they're detained for 2 or 3 or 6 months, not depending on oral meds. And then when they come out, we're not having to worry about this, can I get a 5-day script and run over to Walgreens and pick it up, and I don't have a ride, and I really just don't feel like going to get my medicine because they're on an injection, and then they're still stable by the time they get to the mental health center. That's huge. I mean, it's a game changer as far as recidivism goes. It really is.
And to add to what Allison's saying about our relationship with law enforcement, if you look across the state, every year there are 3 groups that usually come in and support our budget request: the State Probate Judges Association, the State Sheriff's Association, and the State Jail Administrators Association. Because one of the things that they have figured out is if we have a really strong mental health system, we'll keep folks out of jail. And so that's been the big push from their side to figure out how do we work more closely with the Department of Mental Health, which I think is stronger than most other states.
Yeah. You've both spoken to me in the past about the strength of individual relationships and building them. And what you've just spoken about, Dr. Rogers, is really, sometimes we think of sort of unlikely allies or folks who may not be seeing the same thing with relationship to access to behavioral health care. How do you all build those relationships in South Carolina to make things like that work?
Well, this lady here is a genius. And she is really a natural. So last year we were here with Sheriff Leon Lott, who's our sheriff from Richland County. And Sheriff Lott has been very vocal about his support for mental health. So when he's doing a press conference, one of the things that will get thrown in very easily is if there was a mental health issue or something that mental health did well, it gets spoken about from that level. Extremely popular sheriff. And so it's helped to get the message out about decriminalization, for example. He's one of the first people to talk about we shouldn't be locking up mentally ill people. That's insane. And so I think when you have law enforcement that's really able to take that message in a relatively conservative state, it allows the message to get out in a way that neither Allison or I could really talk about. And so to your point, I think there is a lot of conversations behind the scenes for how do you actually shape a message that gets to the population that you need to hear it.
Yeah, great. Allison,
I was just going to say some of the mental health centers, I certainly agree with what Dr. Rogers is saying, that getting citizens involved, right, that have, they may have a family member that has mental illness, or they may be a former clinician, right, in their past life, but they also have some deeper pockets. Some of the mental health centers have set up actually nonprofits that are kind of attached to the mental health center. And I think that allows the conversation to go out into the community in more neutral and less stigmatizing ways. And then also allows for this investment in the community, or in the community mental health centers, that maybe we would not have if we didn't have people that have kind of made this their personal mission of fundraising and of donating and of contributing to workforce functions or needs of the center or needs of the community.
That's excellent, Allison. I think what I hear you saying, correct me if I'm wrong, is that they've set up separate 501c3 entities in parallel with the public system, so that the 501c3 can accept the donation to
And they
support the
can
public
do
system.
things like, an example would be, we had a patient that had schizophrenia. He was a really talented woodworker, and he had a little bump in the road, kind of got off his medicine, ended up detained for a while, came out, all of his woodworking tools were gone, right? I mean, this was this man's lifeline to staying healthy, honestly, along with medication. So the 501c3 was able to step in and purchase that for him so that he could go ahead and get his feet back on the ground and get his livelihood back up and running. So really, small things that you wouldn't think necessarily about that the state system might not be able to do,
Right.
but that a 501 can. So.
Thank you, thank you.
Was that positive?
That was.
Okay, good.
That was positive for me, not South Carolina style, New Yorker style. We sort of have time for one more question from me, and then I want to invite in the virtual audience and our folks here to the two mics on either side, and if you need one brought to you, just gentle waving. Dr. Rogers, when I was sort of fumbling over your introduction, I reflect upon the fact that you held a leadership position in South Carolina, which is now in your rearview mirror, as I like to say. So as it's in your rearview mirror and you're looking forward, what do you think about your time in South Carolina? And if you could, are there any loose ends you wish you tied up? Is there any magic wand you want to bring to the state? What would you do upon reflection?
We've had this conversation a lot in different settings. The thing that's interesting about leading a mental health agency is most mental health commissioners in the United States last for about 2.6 years. And the reason that tenure is relatively short is because at some point you're going to tick off a legislator who's going to say, I don't like this guy, he's got to go, or a governor. Either one, so something is going to happen. So I think that one of the things that I look back on in South Carolina is I think that we were making a lot of positive movement toward our relationships with our federally qualified health centers, because what I truly believe is if you can really begin to blend the public mental health systems with some of our FQHCs that really are providing medical care for the same populations, that you really can build a system that keeps people healthy and well. And I think that was a project that we were really starting to see a lot of momentum from. And so I wish that I had more time to be able to really cement a lot of those relationships a lot more. As it stood, we were able to get about 4 of those done, where we have clinicians that are actually shared across the two populations. So we have behavioral health clinicians that are in the FQHCs, and we have some of our nurse practitioners that are over providing physical interventions for us. And so I wish we could have seen more of that.
Yeah, great. I'm not going to ask Allison to reflect on you, but I will welcome questions from the audience if we have any, or from our virtual audience, or I'm just going to keep talking, which I'm very good at. All right, we have some folks who need mics.
Hi, good afternoon. I had a question for Allison about the 14-day clinic that you talked about, and I know that it's in the beginning stages, the one that you got the one-time funds for. What were your ideas about sustaining that? And I know that you're in the beginning stages for that, but are you going to go to the legislature once it's established to sustain it once it's set up?
Yes, ma'am. So we've been we've communicated with them kind of all along the way about some of the challenges of that. That money actually came in during COVID, and so it was hard to obviously kick off a congregate care setting during the middle of COVID. So that bought us a little time. And then the sustainability plan would have obviously been money from the legislature, and then also any funds that are in reserve that the department may have, partnering with other community partners, law enforcement. The plan is that, not law enforcement, I'm sorry, if an emergency room sent someone to the crisis stabilization unit, so it's relieving their ED, their emergency department, they would reimburse $500 a night that person stayed. So that was the kind of key component to the crisis stabilization unit, along with obviously sustainable funding from the legislature.
And the other thing along those lines as well is one of the things that we did last year is the governor actually appointed DMH to actually work with our state Medicaid agency more closely to look at how do we roll out some of our funding. And so there's actually a budget request that's in for this coming fiscal year for about $8 million to actually be able to build upon some of the things that we've already done so far. So we're hoping that in that budget request, which is actually coming from 2 state agencies, that some of that funding will be forthcoming to sustain some of the programs that currently exist.
Thank you. I'm going to take this one from the virtual audience in front of us. Does 988 connect with mobile crisis response in South Carolina, or is 911 the only way to request a mobile crisis response?
So 911, you can access mobile crisis through 911 or dial directly the 833-364-2274 number. And that is where a master's level clinician answers the phone, triages the call, and if warranted, then deploys the 2 mobile crisis clinicians. And those clinicians then call law enforcement and say, hey, we need an assist on scene. So 2 of those. And the 833 number was the one that we had over 20,000 calls come in last year. So it's certainly being utilized.
Great. Thanks for clarifying that, Allison. I think we had, here's another question. If you could state your name and affiliation, that'd be super helpful.
Hello, everyone. My name is Eric Rothler-Yuan. I'm a psychiatrist in San Diego. And until recently, I was congressional staff and had the opportunity to be the staff director for the 988 and Crisis Services Congressional Task Force. And so I saw this dynamic that you were describing where a state would say, it's an unfunded federal mandate, okay, federal government, let's pay for it. But on the other hand, federal legislators would say, well, if the states want it, they can invest in it. And so we had this the cycle of hot potato. And this specifically came up with South Carolina. As you likely know, there are a number of news reports about how there was one center earlier this year and it wasn't funded. And so one of the things I did was send an email to all 7 of South Carolina's members of Congress and the House and didn't get a single answer back about interest. And this was, it was hard. Nancy Mace even had been quoted in one of the newspapers as this was a top priority of hers. And so there's just this disconnect. And so my question is, have you found that there are any sort of advocacy groups or constituent groups or political groups that you feel have some voice in order to stand up in the priority list for either at the federal or state level for some of the states where dynamics are like this?
I think that part of the challenge you've got is, you pointed it out, is South Carolina has 7 congressional districts. 6 of those 7 are fairly hard right districts. And not to bring politics into it, but I think that one of the things that those districts really do think is we should lower taxes and we should not have unfunded mandates. And so if you look at South Carolina this past year with the huge budget surplus that we had, the decision was made to actually give every citizen of the state an $800 rebate versus investing in services. And that wasn't just mental health services. It was social services for a lot of our kids. It was physical health services. I mean, you name it, a bunch of things were not funded. And I think that gets to be a philosophical decision. So I'm not really shocked that you didn't really hear back from folks. I think there are conversations that are occurring internally but it really truly gets into, is this something that is highly important? And if it is important, why is the federal government not investing in it? And so that's the way that things are kind of getting processed on a local level. And so I think a lot of those conversations locally just aren't occurring to the degree that we would want.
All right, thank you, Dr. Rogers. Over to the left side of the room, name and affiliation, please.
Yes, hi, my name is Mark Pomper. I'm here in an independent capacity as a parent of someone with serious mental illness, looking to get more involved in advocacy work. I guess my question really goes to your comments about being data-driven in the state. And it just struck me that, you're talking a lot about the costs of setting up a center and getting funded and so forth. So we're always talking about the cost, but in terms of framing the argument, kind of cost-benefit analysis also should be part of the picture. So have we kind of quantified the cost of not doing anything? The cost of, winding up putting somebody in jail as sort of their long-term health care plan, or tying up the police department with all the call-outs to mental health and so forth. So have we ever framed the debate in terms of the cost of not doing something?
So we tried doing this. So working with folks from our School of Public Health and some of our EPI folks, we actually went back and tried to do some cost analysis and some forecasting. The challenge you run into when you're trying to convince a legislator that something is going to save money is you can't prove it. It's all speculation. And so I can tell you that if you give me $5 million to stand up X, I'm going to be able to save you $10 million. And the response is always, prove it. Because if I give you $5 million, more people are going to show up. And if more people show up for mental health services, it's going to cost you more. And then you're going to need more beds. And so it was actually a very reasoned explanation on the other side. And as I was listening to it, I was thinking, you're actually right, that it will cost more as more people decide to seek services. And so if you look during COVID, for example, one of the things that started happening is a lot of systems found that their budgets actually started to go into budget deficits because of the need for more services. And so I think to try to prove some of those things becomes really problematic in kind of talking about it. Because on the flip side, it's hard to know what the uptake is going to be, and it's really hard to know if there really will be a savings or not.
Thank you.
Allison, did you want to add anything to that?
Nope, thought he did a great job.
All right, wonderful. Over to this side of the room, name and affiliation.
Hello, my name is Oyewumi Oyeni, and I'm a student reporter with YMG. And my question was, are there any considerations that may make disenfranchised communities more or less inclined to dial 988, and what could help?
I think that comes down to, it's a complex question with a complex answer. But until we are communicating and we have we are sending a message that the people that need to hear it can receive, which sometimes I think we miss the boat on that, right? Like sometimes we think, oh, this is a great message, but then the people that it's aimed towards, it's not the way that, it's not their language, it's not the way that they can receive something that's meaningful to them. So I think we need to work on that. I think it all goes back to stigma too, that some of the disenfranchised communities, there's high levels of stigma that maybe have to be addressed in unique ways. And each little, each little tinking away at it matters and is worth it, but it's going to take human beings and time.
And one of the things that's unique about South Carolina too is we have the second highest African American population in the United States. And so we've had to think a lot about, especially African American population stigma and how to get the message out. And so part of what we've tried to do is a number of campaigns, not just for 988, but for mental health in general. And so we've tried to partner with community organizations. Church, of course, is a big thing in South Carolina. We've tried to partner with a lot of religious organizations to get the message out as well. One of the discussions that was part of that was 988. But I think we're, as a state, at the infancy of 988 so much that even if I gave somebody the 988 number, I don't know what's going to happen on the other end, always. And that's the piece that worries me just a little bit. If someone's calling 911, I almost know what's going to occur because it's really well established. And I can have some sense of what the outcome is going to be. And so I think with our African American populations, for example, a lot of it has been conversations around how to seek services, how to actually ask specifically what you want when you're calling 911. So for example, we had some bad outcomes where folks were shot. And so in that particular situation, it's how can you really say, this is what's going on. As Allison was saying earlier, these are the kind of officers I would like to come out, and we can actually do a really good job of doing that through our 911 system. I think that's much less clear through the 980 system.
Thank you. We have time for one more very brief question.
It'll be
Over to
very
you.
brief.
Thank
you,
you.
Mellissa. Thank you, Dr.
Yeah.
Rogers. Thank you, Allison. Raul Andrews, APA Foundation. Always, as we sit here, Dr. Rogers, I was struck by your comment about the 2.6 years that someone like you would stay in your role. And we're all kind of reacting or trying to take in what New York City is deciding to do. And so my question is, as we try to meet the growing demand for mental health need, the people who we've relied on to do the work are leaving the job because they don't have anybody taking care of them. Did you see any of that as you've looked at these 1,000 portals of entry that the provider says, you know what, I can't do this anymore?
We've had a lot of people leave mental health, and we've had a lot of people leave our system. Interestingly, it's been the psychiatrists who have actually left at the lowest rate. Number one has been our master's level clinicians. We have had a mass exodus of folks that said, I've done this long enough, I'm going home, I'm going to do a virtual job, and that's really it. The second group has been our nurses. We've had nurses who have exited in droves as well. And a lot of it gets to the things that you're talking about, is the political piece of this. If you look at what's happened with mental health and with education in this country, you get demonized about a lot of stuff. If something goes wrong, it's automatically your fault. If there's not enough beds, it's automatically your fault. And to your point, I remember having a conversation with one of our legislators around, can you open more beds for me within the next 3 months? And my response back was, I can't do it in 3 months because I can't get the staff hired fast enough. I won't repeat the response that he gave me because it's not appropriate for public consumption. But it was essentially blaming me for something that couldn't be done by anybody because you don't have the staff to be able to do it. And so to your point, I think there's a place where people just decide enough's enough and I'm going to go out and do something else with my life.
Well, soon we're going to have to say enough's enough on this panel. But before we do, to make closure, Allison, if you had a quick words of advice for other states, what might you say?
I would say don't try to do it alone. You know, use your resources that are around you, reach across state lines, figure out especially those buffer counties and cities that, you know, sometimes it just kills me where I'm like, God, if only somebody in Charlotte could get right across that line, right? They could get there in 10 minutes, whereas I'm gonna send somebody that's gonna take them 30. So that would be my advice, like get creative, see what you can do, see where you can bridge some of these gaps by just stretching a little bit in ways that might be a little uncomfortable, but would work.
Right, all right. Dr. Rogers?
Stay the course and not let frustration take you over. Because I think it's very easy to become disenfranchised, to become frustrated, to feel like things are hopeless. But as you look around, there are a lot of places where things are actually going well. And I'm hoping that coming out of the backside of COVID, that we will begin to see a really confluence of dollars being available, but also the hopefulness that was built by mental health during COVID also coming into fruition at the same time. Psychiatry is actually the #1 specialty in medical school now. And that's been the case for the past several years. And just like that's happened, people are really beginning to understand I can have a career in mental health. I can have a career with helping people. It's just a matter of how do we continue to sell that? How do we continue to encourage it? How do we talk to young people about careers in mental health so that the next generation will be there?
Great. Thank you so much to both of you. Excellent
Thank
job.
you.